Okay, welcome everybody. We are at the top of the hour. Thank you so much for joining us tonight for another edition of AO Trauma North America's Fireside series. Tonight we're going to be talking about all things humeral shaft fractures, MIPO, IMN, ORIF, and obviously not to be forgotten, the non-operative treatment. We've got a great panel here tonight. Myself, I'm Mike Gardner from Stanford. We have Julius Bishop, also from Stanford, and Joe Cohen, who is from Loyola in Chicago. Just a couple brief housekeeping items. These are our disclosures, nothing related to the information or the content in this webinar. Brief statement about what the AO and the AO North America is for those of you not familiar. It's an independent nonprofit specialty society that's really dedicated to improving care of patients with musculoskeletal injuries. Does not promote, and we do not promote, any specific products or commercial devices. And the implants that you'll see in some of the x-rays in this talk are meant to demonstrate a teaching principle and not to promote any specific manufacturer. Briefly on Zoom, microphones will be muted and videos are off, but we really welcome any questions. So use the Q&A box to send them in. We will all be reviewing them throughout the webinar here, and we'll answer as many as we can, either typing or live for the whole audience to hear. General learning objectives here. We're going to identify some key aspects of humerus fractures that need to be assessed correctly, treated correctly, with the appropriate indications and patient considerations. We'll talk about current best practices and critical steps for treating humerus fractures, and we'll talk about evidence-based medicine strategies throughout the lecture, or throughout the webinar really, but specifically in the journal club session in the last 30 minutes here. So here's what we have on tap: 8 o'clock Eastern time, which is now. We're getting started. Dr. Bishop is going to go through several cases, actually, for about 30 minutes. And then Joe will talk about 2 cases. We will have a journal club discussion, wrap up, any additional questions after that. And then we will adjourn right around 90 minutes from now. So without any further ado, we'll jump right in to Julius to take us through this first case.
Fantastic. Thank you. Thanks everybody for joining. And so here's going to be our first patient. So this is a 50-year-old man involved in a motorcycle crash. We're going to focus on his diaphyseal humerus, but he also has a left-sided chest wall injury with multiple rib fractures. You can see just on the edge of the slide there, he has a diaphyseal clavicle fracture through the site of a previous malunion, and then also a fracture at the inferior pole of his scapula. With regards to his humerus in particular, this injury is closed. He has normal motor and sensory function, no vascular injury. In terms of his shoulder, he had ORIF or proximal humerus fracture about 10 years prior. And per history, the shoulder has never quite been the same, with his primary complaint being stiffness. So this is our patient. This is the injury that we're going to focus on, and these are the decisions that need to be made.
This guy is a true trauma patient, it looks like, huh?
He is. And so I think there are a lot of decisions to be made here, but here are some of the most obvious ones, and maybe I'll just pitch these to you guys. Is this for you an operative versus non-operative injury? And then assuming operative treatment, how are you going to approach this problem?
That is a good case, Julius. I mean, I think the more I do this and the more I read about this, the harder these decisions become. is he someone that is like awake and alert and you can actually have a conversation with?
He's in the ICU because of his chest wall. He has a lot of rib fracture pain, but he's awake, alert, reasonable, engaged in the decision-making process.
Yeah, I mean, I think all closed humerus fractures have a pretty good potential to heal, in my opinion. So I think that's always a consideration. He is technically polytraumatized. Do you think, did that play a role in how you decided what to do in this one? Or were his injuries?
I set the bar pretty low for polytrauma when I'm thinking about humerus fractures, because I think it doesn't take many other injuries just to make this exponentially more miserable. So even if your only injury is, humerus and clavicle or humerus and chest wall, I think that's exponentially more difficult for the patient than humerus alone. And so polytrauma for me in general is like one other injury, because I find that just makes non-operative treatment so much more difficult.
Mm-hmm. I also feel like the conversation is just inherently different when you're meeting these people in the hospital and they have multiple other injuries versus when they're coming into clinic. They've been told by the residents or other people that they need surgery, so they already have an idea in their mind of what they need, and you're potentially talking them out of something that they heard before. But yeah, no, I agree. I'm more aggressive when they have other injuries, just because it facilitates their rehab, facilitates their recovering from their other injuries, getting out of the hospital, and ultimately getting back to their previous state. So yeah,
go ahead.
No, I think I'd be leaning towards operative for this one. And then deciding whether or not to do a more minimally invasive or a more open approach. I don't have a ton of experience doing the minimally invasive plating techniques, so I would open through a delta pec or extended anterior lateral. Is that the incision he previously had, or did he have a direct?
Yeah, good question. So he had a previous delta pectoral approach, well healed.
Yeah, and then I would plate on the anterior surface of the humerus, which is more anterior than I usually would if that plate wasn't there, versus taking out that plate and putting a longer plate back on.
So you're going to maintain previous implant, open approach. Are you thinking you're going to do a direct anatomic reduction with lag screws and neutralization, or you're thinking you're going to bridge this pattern?
Yeah, I mean, if I was gonna, I would probably open it. And so at that point, I would assess how much comminution there is. If there's pieces that I can clamp and reduce and put lag screws in, that's my preference, especially if I'm going to be taking out the previous implant and putting in a long implant. I think it's just hard to place that contour, to get in the right spot and then still be happy with your reduction. So that tends to be what I do if it's possible to do that. If there's too much comminution, then I'll bridge. I try not to open and strip all the fragments and then bridge.
Yeah, that's always the trap. I think for this one, if I were to open it, that big medial butterfly is pretty enticing for me. You always can be fooled, but this looks like one that you're going to be able to anatomically reduce with clamps, and then with interfragmentary lag screws have something that's pretty satisfying if you choose to go that route.
Yeah, I agree with both you guys, I guess, or that on the indications, it definitely is harder for a person to tolerate a fracture brace for 6 weeks, say, with a fractured clavicle and a fractured scapula, fractured ribs, etc. Even though traditionally, the polytrauma relative indication for some of these upper extremity fractures, it's a little vague as to what that really means. And I mean, I think the way you described it is reasonable. It's also been kind of likened to one of the more frequent kind of justifications is to allow for crutching around for a lower extremity fracture. But certainly just comfort and general upper extremity mobilization in multiple fractures is a reasonable one too. Yeah, and so basically you would have to take the plate out if you wanted to use an intramedullary nail, and that wouldn't be a horrible implant definitively in general, but it's not in my mind so desirable to warrant taking out this previously placed implant. You could use part of that exposure for the nail starting point, but there's kind of no need to do that really. So yeah, I mean, I would still have a discussion with him, and some people, I agree, Joe, it's totally true. Like they see their X-rays maybe, and somebody's telling them the ER resident, you're going to need surgery, but some people are like when you say that when they hear that they may not need surgery for this, they're relieved, and so they're happy to try that. But so yeah, I'd still see where he stands on the spectrum, and I wouldn't just tell him he needs surgery, but I would advise him that it probably would make life easier for him. Surgical approach, yeah, I mean, I probably would just use a posterior approach. I agree, it's very hard. It's hard to really I could probably count on one hand the number of times I've truly bridge plated a humerus fracture. The typical like construct details that we see with the more typical bridge plating areas, like the distal femur or bridge plating, bridge plated distal femur or distal tibia or other things. It just doesn't seem to work quite the same in the upper extremity in a non-weight bearing bone where there's mostly torsional forces. So yeah, it's almost always delicately mobilize and clamp and lag and then just apply neutralization plate. So I would probably do that posteriorly, I think, as a pretty standard humeral shaft approach for me anyway. But certainly anterolateral is also very much standard and acceptable.
If this was a isolated humeral shaft, do you think the success rate of non-operative treatment is high, somewhere in the middle, or is this one you think may not heal or become a non-union?
No, I don't think there's any risk for, some of the larger studies on non-operative treatment of humeral shaft fractures have tried to ferret out risk factors, and we think based on the strain theory that mid-diaphyseal transverse are going to have a hard time healing with relative stability and fracture site motion. Turns out it really hasn't borne out that way in the literature, and the majority of really all patterns heal more often than not, or at least at a close enough rate to be undetectable in the series that we've seen. So, but this in particular, I think would be even more likely to heal given the amount of comminution. So if the patient was up for it, I would tell them this is a very high chance this will heal without surgery if he can tolerate the non-op pathway.
Yeah, in isolation, I like this one for non-op because it's multi-fragmentary. Anecdotally, I'm a believer in the old Sarmiento thinking that the widely displaced transverse probably does not respond well. And so for those, I tend to be more aggressive. I guess the other thing for me here is the stiff shoulder. I think the stiff shoulder is a real problem for non-operative management of a diaphyseal humerus fracture. We have a pretty big geriatric population where that tends to come up all the time. And I do think that makes it harder, which makes sense. If your shoulder doesn't move, then the fracture site's going to see more of the motion.
All right, so yeah, so we're all leading surgery. Julius, there's a question in the Q&A. What's your thought process on timing for surgery?
Oh yeah, I think this is a gray indication. And so this particular patient, as you may have deduced, he's already had ORIF of another grayly indicated fracture at the upper end of his humerus. And so he was pretty bullish on surgery. But if it was me advising the patient, I'd tell these patients, time is on your side. If you want to try a fracture brace and see how you tolerate it and see what the alignment looks like, then I think that's a pretty reasonable thing to do. So my usual thing for people who are on the fence about surgery would be to trial them in a fracture brace and see them in a week. And usually that's pretty effective, I find, in distinguishing between the people that are going to be able to kind of work through that and manage with the brace and the people that are just absolutely miserable. And so I certainly wouldn't twist this patient's arm if they wanted to try non-operative treatment. That being said, if they wanted to do it, then I think doing it helps with pain control, helps with mobilization. And so in that situation, I would just do it right away or as soon as it's medically appropriate.
So let me just dig in on one thing you said. So you alluded to, during a trial of non-operative treatment, assessing the alignment. So how heavily do you weight alignment in the first week? And do you have any thresholds you use? And what have you seen about patient acceptance of a humeral malunion?
I think in my, now decade plus of practice, I've only ever operated on one humerus malunion that was like 45 degrees, like in a guy with a skinny arm. But I find that the malunited humerus tends to be very well tolerated. And so I leave it really up to the patient. I think this is really like the bell cow for, it's not a malunion unless the patient says the arm is too crooked. I think some of these historical numbers for what you can accept and can't accept aren't really data based. And so that would be my answer to that. In terms of early follow-up, as you know, our residents are always going to get, more often than not, patients will go straight into a fracture brace, and almost always they're going to get an immediate post-brace x-ray. I put very little weight on that unless the deformity is just ridiculous. And so to me, I am interested to see what it looks like at 1 week in the brace. I think that is helpful. I do acknowledge that most patients are not participating in much active motion in 1 week. So probably the brace is not really functioning as it's intended, but that would be my answer to that. Initial alignment, I more or less ignore unless it looks ridiculous. At 1 week, I am paying attention, but I'm also acknowledging the fact that I'm not getting the real effect of a fracture brace because most patients, at least in my practice, aren't able to do meaningful active motion after only a week.
Yeah, it's interesting. I mean, I definitely agree. It's interesting. I just saw a patient who's like non-op, little varus, but she's a skinny woman. And I don't think I've ever treated a humeral malunion for a patient cosmesis issues, but she's actually like, my arm's crooked, looks funny. I don't know. You said it was going to be fine. Doesn't look fine. Like it's okay. And yeah, she'll get over it and she'll function just fine. But they heal in varus pretty readily, and it's not nothing to every, but anyway, it probably still doesn't justify an operation. And so speaking of that, Joe, maybe I just ask you, what do you tell? So if you're going to do question the Q&A on a posterior approach. So if you're, I forget what you said, maybe you said anterior approach, but if you're going to do a posterior approach, how proximal do you extend the plate? And then part B for me is, what do you tell them the risk of radial nerve palsy is?
Yeah, so if I'm going to anatomically reduce and lag the butterflies, I think the plate probably can be a little bit shorter. If I'm going to truly bridge this, I'll probably send the plate almost all the way to the maybe that second hole in the plate's almost to the neck there. And so I usually go for 3 bicortical screws spaced every other hole. So I'll try to get 6 holes of the plate above that segment.
If it's all lagged back together?
If it's all lagged back together, I think you could maybe go a hole shorter, but I tend to put longer plates with fewer screws than short plates with less screws.
Gotcha. Let me ask you another one. I like that we're talking a lot about non-op, and we'll get to what happened here in a minute. But what's all this talk about? You read in the books a coaptation splint for a few weeks followed by a fracture brace. Joe.
Yeah, I mean, I think there's some push towards early or early fracture brace if that's available. I think the way I was trained, the way a lot of people are trained, is they put the coaptation on and it fits terribly, and patients don't really find it that comfortable, but it's maybe more comfortable than a brace squeezing directly on the arm. But I don't think the coaptation really does much in terms of aligning it well. So we currently still do, because we don't have fracture braces in our ER, we are currently still putting coaptations on and then switching them out to a fracture brace at about a week when they come to clinic.
Yeah.
But I think an early fracture brace is probably would be my preferred way to go.
Yeah, it's interesting. Just a quick sidebar. When I was in St. Louis, we had two patients not far apart who had like near full thickness skin breakdown in their axilla from coaptation splint, like rolled up, not enough Webril, right? Sweaty, and they break down because they can't really move. And so we started a randomized trial of looking at immediate, and so we look back into all literature, like why a coaptation splint? This fracture brace definitive. Why not? And there's not much actually. The original Sarmiento stuff kind of cites swelling as a reason to use a coaptation splint instead of a brace. Doesn't really make a lot of sense. Probably is a little more comfortable, assuming you don't put a big wad of plaster in their axilla. And it does seem to be more of a logistics issue. Actually, in that study, we had a hard time getting fracture braces with like the patient billing and all that stuff in the ER. But we kind of currently do that now. It just works out. We have them available, so we generally do that. But
yeah, I'm a fan. If I had a humerus fracture, I wouldn't consent to being placed into a coaptation splint. No way.
Yeah.
All right. So, Julius, why don't we see what happened here, or
All right.
things you want to talk about?
No, I think that's good.
Oh, did I? Is it on annotate or something?
It looks like it's on annotate. Ah, there we go. Yeah, this thing's running away from me.
Back arrow. There you go.
All right. Perfect. So this was my maiden voyage, actually, of MIPO plating. And so I'd kind of been monitoring the literature from the sidelines on this one. And I don't know how many of you are familiar, but the literature support for this is actually impressively strong. And so to me, this was a polytraumatized patient. He had a significant chest wall injury. I thought time under anesthesia would be relevant to him. He had a multi-fragmentary pattern that I thought was amenable to bridging. And so this was my maiden voyage. This is a photo from the literature, not from this patient. But this is, just like we would do in the distal femur, an indirect reduction and then sliding of a plate. And so I've used a 3.5 LC-DC plate in pure bridge mode here, from up to down, with just a focus on length, alignment, and rotation. And this is what I did. I fixed his clavicle also at the same time. You can see I left his proximal humerus plate in place. I just used the most distal aspect of his deltopec and made it a little bit longer. Here's what I did. Reasonable, unreasonable?
Yeah, I mean, it looks pretty sweet. I mean, I've only done it once. It's been a while now, but you'll read the techniques about, I guess, like Kevin Tetzworth does this a lot, and he talks about a 2-pin X fix for the reduction. I'm not sure if that's necessary. Once you get a screw in and you can realign the distal fragment to the proximal kind of thing. But yeah, you see X-rays with 3 screws on each end of a long plate and comminution, not reduced, but length, alignment, and rotation restored. And they seem to heal very quickly, and patients Patients seem to love it.
Yeah. So here's what I did. And then let's see if I can do this properly this time. Here's what happened. So here he is at 3 months, and you can see he's in the early stages of healing. His implants are intact. His alignment is maintained. He has callus medial, callus lateral. His wounds are healed, and he's doing well. And so this was again the maiden voyage for me, and actually really made a believer out of me of a procedure that I think makes a lot of sense. And so this is not an every time thing for me, but especially in patterns that are multi-fragmentary, where I think that I may not get my money's worth from an open reduction, or where I think that an open reduction is really going to be physiologically relevant, because these can turn into, you know, a pretty large raw open surface. I think this is something that I always keep in mind.
That's awesome. Really like it. And so there's a quick question. I was typing it out, but risk to the radial nerve.
Yeah. So it turns out that the risk to the radial nerve, it looks like, is less with this as it is as compared to conventional open approaches, at least if you believe the literature. And so I get, you know, some people have this philosophy of if you don't see and dissect the nerve, then you're afraid, and you know, and that may not be the most responsible thing. But you know, I think at least here, you know, the proof seems to be in the outcomes that this is a safe and responsible thing to do, despite the fact that you're not visualizing the radial nerve.
Yeah, and I mean, you would think like if you superimpose the course of the radial nerve, you know, in your mind's eye over this, it's, you know, distally or definitely central to it or medial to it, and so you shouldn't be really too near it in any of the areas you're working, I wouldn't think.
Yeah, I mean, it makes sense. It's safe from what we know about anatomy, and the literature bears that out.
Yeah, awesome.
Great.
All right, great case. Why don't we go to your next one?
All right. So there's soft tissue. Let me get you the next slide here without overshooting. So take home here, surgical treatment is best for some patients, as we touched on. Plating and nailing in a conventional way, both have some drawbacks. And so I think, it's good to know about this minimally invasive technique. And if you're unfamiliar and feeling anxious, I think you can be comforted by the amount of support that there is for you in the literature. If I can get this, or if anyone can get this to go back 2 slides, if anyone wants to take a.
Am I moving that by typing answers here? Am I moving your screen somehow?
I can't tell.
I just messed it up. Sorry. Maybe the typing takes back control. So I think just click on it and then you should be able to move it.
Aha. All right. That was the problem. All right. So anyhow, this is a good jumping off point, and the aforementioned Dr. Tetzworth has a paper in the Yellow Journal, and this is a little bit old now in 2018, but is a good jumping off point to at least start sampling what are the outcomes, what are the surgical techniques, what are the rationale. So if you haven't done this technique before and you're interested, I would send you to this paper first. Okay, next patient. This patient is 28. Yeah, he's young, healthy, muscular. He was at his bachelor party in some sand dunes that are like an hour south of us here on the West Coast. And he was in one of these dune buggies with his arm hanging out the side when they rolled it. And so he has this isolated, closed, metatarsal distal humerus fracture, normal radial nerve exam. And this is his injury film. So I guess same questions. What do you guys think?
Very,
Go
very
ahead.
similar thought process. Again, this is a long conversation with the patient about what their goals are, what they want to return to, and how much risks they potentially want to take to get to those goals potentially sooner. I think a lot of patients look to you to tell them what you would do or what they should do. And I think it just becomes a really long conversation about the options and pros and cons, and then I'll try to get a sense of what they actually want, if they're really scared of surgery or if they're more willing to take risks to potentially get back sooner. I think this one in particular, I would tend to push him towards surgery, probably for a couple of reasons. One, I think if this develops a non-union, I think his radial nerve is going to be pretty much inside of that fracture site. So the chances he gets in a radial nerve palsy from a non-union surgery, or let's say in 4 weeks he decides that he wants it fixed, I think the chances of a radial nerve palsy at that time are significantly higher. Whereas the risk of a nerve palsy at early fixation much lower, and the chance of, if that does happen, that it resolves are very, very high. And so if he does want to get back to either working or using his arm quicker with maybe more predictable healing, I would probably tend to push him towards open reduction, internal fixation through a posterior approach.
Yeah, I think that's totally reasonable. This guy's active. He goes to the gym. I think he has a desk job, but this was his bachelor party. So he has his wedding ceremony coming up, and he's in deep trouble that he's potentially compromised the honeymoon and so forth. So he does value rapid recovery.
Yeah, I'm
So
kind of the same. You know, I generally tend to massage the conversation towards ORIF. I think it's more predictable. There's not great data to support it for this fracture pattern, but the arm heals straight, early return to function. Taking care of a non-union, which is 20% of these, is a much bigger endeavor.
I think you also have to be honest with yourself and your own skills. If you're someone who does not dissect the radial nerve frequently, maybe you should try to treat more non-operatively, because you are putting that at risk. But if you're someone who does this a lot and feels comfortable with it, then it may be more appropriate.
yeah. If you guys are both operating, is either of you doing anything other than a posterior approach with a direct reduction, lag screw neutralization, anything different than that?
Nope, that's it. Do you consider this question in here? Do you consider this a Holstein-Lewis fracture, even if the radial nerve is intact? And does it matter?
I guess my answer would be I suppose so, but I don't really pay attention to that, because I haven't found in my practice, and I think it's been borne out in the literature, that that's not such a harbinger of doom for the radial nerve as previously thought. So I think this would fit into that Holstein-Lewis description, but I personally don't pay much attention to that when I'm making decisions about how to manage this. So I guess I was a resident in Boston at the time. Andy Jawa was doing one of these early retrospective cohort studies looking at operative and non-operative treatment. And I've probably been biased by that some. And so I like to give these a go of non-operative treatment. And I've been really impressed at how well things can work out. So you can judge for yourself how well this worked out or not. So here we go. So this patient was seen at an outside hospital. So you got an outside injury film, and he goes into the aforementioned coaptation splint. And here's how he looks. It looks not better, perhaps worse. He doesn't get much of a valgus mold on there. And he has probably the characteristic internal rotation deformity that you always get when you put the fractured distal humerus into a sling, you know, with the arm on the abdomen. And so here's how he is. Does this, you guys are both voting for surgery anyways, does this sway you in any way?
No, I mean, the gapping on the lateral, you know, is just never great to see. Although it's not a red flag that it can't heal with that, but it just seems like it would be harder to get to heal.
Yep.
Yeah, I agree. I think it would just be more reliable healing if I fixed it at this point.
Fair.
But it's not
Okay.
totally reasonable to have that conversation about, just because it's distal doesn't mean it can't be put in a fracture brace.
Fair. Yeah. Yeah, I think that's a good observation. So I'm going to persist here. And here I go. I'm in my fracture brace. I have some relatively simple fracture patterns with large gaps. You can see I have some disability and some pseudo subluxation at the shoulder as well, which is always hard to look at and very common, I find. And so here I am. But the patient now has bought into non-operative treatment, and so we're going to continue. I think for sake of time, I'll just continue on. And here we are at, I think, 4 months. And so, you know, the fracture callus, I think, is generally pretty kind to you. It sort of masks your varus malalignment here. But this patient is healed. He's comfortable. His pseudo subluxation has resolved. As with all these patients, if you palpate their lateral aspect of their arm, you can feel that bump in their metaphysis. But as previously mentioned, I think it's pretty uncommon that that bothers somebody. And so for me, this is a win of an outcome. And so here he.
Sorry, do you have a time point, like an early time point that you would change your management? Like if you saw no callus at 4 weeks or no callus at 6 weeks or motion at 6 weeks, do you use any of those potential maybe predictors of non-union for these?
My general mantra is that 6 weeks is too soon to see impressive callus, but I do sort of use that the joint disease, you know, if the patient can't give you a firm handshake at 6 weeks, that's a poor prognostic sign. But I still don't force the patients. I just tell them, you know, at 6 weeks, if you have motion at your fracture site and your function of your arm is poor, that's a bad prognostic sign, and we should at least consider doing something more aggressive. But even patients refuse, and sometimes that works out, even though in that particular series the results were poor. So if you see this particular guy, you know, if you're if you're critical, you can see the varus when he has his arms at his side, but you can see his elbows functioning well, his shoulder is functioning well, and he's pretty enthusiastic about this outcome.
Nice.
And so, again, distal third fracture bracing can still work if you treat the patients non-operatively. That's okay. If you treat the patients non-operatively, you're definitely going to have deformity, but it's pretty questionable how significant that is. And if you treat them operatively, you know, it's going to be better aligned, but you're going to potentially have surgery-related complications. One quick paper for people that want to dive into this. This is one of these clinical face-offs from CORE, which I think are outstanding in sort of, it's a, you know, a debate format of the pros and the cons. And so CORE 2016, if you want to sort of dig into a pretty quick hitting and high yield article on this topic.
Awesome, thanks. Why don't we do this? We've got some interesting questions. We don't have a ton of time. We want to get to Joe's cases. Let's do a little like, let me ask you, Julius, just like quick hitter questions, like 5-second answer. Malrotation, is that a concern? Have you ever seen a malrotation, malunion of the humerus?
I think every patient I treat non-operatively gets some degree of internal rotation. I've never had somebody come complaining that they want something done about it.
Nice. MIPO plating of the humerus, weight-bearing status.
My general philosophy is if they don't absolutely need to weight bear, I don't have them weight bear because I think the risk reward is not in their favor. But if they have lower extremity and they need it, then I let them do it.
Nice. Hanging arm cast, still a thing?
I think the literature supports it. I'm not particularly trained in that, so I don't use it. I will say I do like a collar and cuff rather than a sling in non-operative treatment of the humerus because I don't like to have the elbow supported.
Nice. And then finally, that shoulder pseudo subluxation you pointed out, does that account for any decision making?
No, it always, I mean, it gives a bad taste in your mouth and the patients notice it. And so it is off-putting, but I don't act on that. Sometimes I will, if the patients have access to PT, I try to little e-stim on the deltoid. I don't know if that makes any difference, but it makes me feel like I'm doing something.
Nice. And then finally, I'll just comment. There was a comment in the chat, a good point where I was talking about no risk to the radial nerve. When you put a home in around the lateral side of the distal incision, that can endanger the radial nerve in that position. So that's important to note, which I failed to note.
Yeah, Homans around the humerus, no for me. Agreed.
Awesome. All right, great. Well, thanks, Joe. Why don't we, let's see. So why don't you take over the remote now and you can drive.
Right. Okay. So this first case was a 70-year-old female who came to me in clinic, a healthy lady, really no medical problems at all, not very active, but she still works. She's works as a preschool teacher. She just tripped on a curb and landed on her arm. And so she came to me with these x-rays, just a proximal third comminuted humeral shaft fracture that pretty much goes all the way to the neck, but does not extend up into the tuberosity.
Yeah, so I mean, in my mind, this is a hard fracture to treat without surgery. You can see it looks like a brace on there, and you can see how inadequate that is, but maybe that in a sling could help. But you know, in order to, how old is she?
She's 70.
Yeah. So in order to mobilize her shoulder, you know, non-op is going to be difficult. Healing, I think, is going to take a while. And so I think if she really wanted to, if she was sick as well, or really was interested in pursuing non-op, it's not totally unreasonable. Obviously, it's a extra-articular fracture, but I think operative treatment would help her healing trajectory and early mobilization. And then I guess just to briefly continue, you know, this is one that's really hard to do ORIF. It's a good one for an intramedullary fibular template because you see these like spiral, less than hemi-circumferential like barrel staves that are just so hard to lag like blade edge and lag together. So an intramedullary fibula is a good like template to lag into if you want to do that. But I think this is,
I've never done that. Can you describe how you do that?
yeah, so there's a few ways, you know, it depends on where the fracture is. You can, through whichever approach you use, you can mobilize the diaphyseal segment towards you and kind of drop a fibula all the way down. Dean Lawrence described, which is pretty elegant, actually using an intramedullary nail portal and putting a fibular allograft down through the head all the way down into the distal diaphysis, doing it that way. And then you can just tack all of the cortical segments to that with mini fragment screws and then support it with a plate. And that actually works out reasonably well. I've done that a handful of times. But I probably would choose this as a good indication for an intramedullary nail. Osteoporotic, short proximal segment, long segment of comminution. Obviously, the distal canal ends much more proximal than maybe is intuitive. But I would say here there is still enough intact distal intramedullary canal to support a nail appropriately. That would be
I think a nail is totally reasonable here. My preference for this actually would be an intramedullary fibula, or if you don't have a fibula long enough, we have these, strips of tibia allograft that are very long, with a direct reduction, lag screws, and neutralization plating. It ends up being a large incision, but I find in these elderly folks, and she's got a skinny arm, that it's not such a big bloody field because there's just not that much muscle to work around. And I personally find that to be pretty reliable and effective, although admittedly it is a large incision.
Do you think this is too proximal for MIPO plating?
Probably too proximal for me. I think it's one thing to be bridging with bicortical screws in the proximal diaphysis. It's another thing to be bridging this length of a segment with unicortical screws into an osteoporotic humeral head. I think to me that is just asking for fixation failure in the proximal segment.
Yeah, I mean, I think if you wanted to do a bridging plate, in isolation, it would need to be kind of a lateral plate. And you can tunnel that somewhat MIPO. You can center it and fix it proximally. You can burrow through the deltoid insertion on the tuberosity. And then you need to kind of find the radial nerve distally on the lateral side, depending how far down the plate goes.
Yeah, I think,
Yeah.
Are you guys, are nails a big part of your practice? They're not for me, but I agree an intramedullary device for this, I think, is perfect. But they're not a huge part of my practice, but for this particular pattern, I think this is a good one.
Yeah, I mean, nails are not a big part of my practice, but I think I probably do more humeral nails than the average North American, at least, orthopedic surgeon. I think it works very well with an appropriate starting point that's medial and not through the cuff insertion, and a countersunk nail that doesn't stick into the subacromial space, and care for the radial nerve. If you avoid a statically locked, distracted nail, and not avoid a prominent nail and avoid injuring the radial nerve, it can be a very successful operation, actually.
Yeah. Yeah, it's not a huge part of my practice either, but I think it does have a pretty good indication and a pretty good track record in the literature for having successful results. The first one I did, I brought in the C-arm from the ipsilateral side, kind of in a semi-beach chair position. And I must have contaminated like 3 or 4 guide wires. It was pretty painful. So since then, I've brought it in from the contralateral side with just a more cantilever type table. But I think positioning for these is key. You can hose yourself big time with a malpositioned patient, or even just a C-arm coming in from the wrong spot. And so I guess some other keys for me is make a large enough approach actually to see and repair the cuff. I don't think this humeral nails really should be done with a percutaneous incision where you just ream over the wire through a really small incision. I think it's important to actually see and repair the cuff and start probably more medial than where the cuff actually inserts on the tuberosity. Which can be a struggle for me. I think the acromion is in the way 100% of the time. Do you guys find that for you as well?
Yeah, sorry, what was the end of your question there?
Yeah, do you guys find that the acromion makes it really hard to actually start in the appropriate spot?
Totally, yeah. So it's a big big point, I think, for doing this correctly. To be medial enough, you need to be anterior to the acromion, because you can't get medial enough if you're lateral and bumping into the acromion. And then to get medial enough to not be too anterior, you need to extend the shoulder. So you bring the center of the humeral head out from under the acromion, and then you can go in front of the acromion and be on the appropriate starting point. So that gets to your point about the setup and the positioning. Needs to be done carefully and thoughtfully to get in the right starting point. Yeah.
It took me a while to figure out that extension part. That is key to not struggling.
Yeah. So I use for actually every proximal humerus or humeral nail, I use one of these pneumatic arm holders, including for nails, and it just makes life infinitely easier, including the part of extending and holding the shoulder where you want it, and for the distal interlocks and everything else. So if you have one of those in your hospital, it's worth checking it out.
Yeah, and then once you have all of that appropriately set up, it's really just length, alignment, and rotation, which for a humerus, length isn't as important maybe as it is for the lower extremity. Alignment probably isn't as important for the lower extremity, and then rotation also they can just tolerate a lot. So I feel like that's why it's a faster procedure than doing an open approach, is because it can tolerate a lot. I think proper nail rotation though is one particular way that you can get in trouble. If the nail is rotated and your interlocks are going from lateral to medial, it just really puts the radial nerve at risk. I know there was a question earlier about humeral malrotation or malrotational malunions. Do you guys have a way that you assess that introp? I know it always happens when you treat people non-operatively, but we try to get people as close as possible when we fix them. Do you guys have a way you assess that?
Yeah, I think it's important to figure out a way. It can happen. I've had one humeral nail where I've had to take out the distal interlock and redo it because it was off. So it's not automatic. You know, I generally try to get the proximal humerus to look like a good profile of the greater trochanter. And then, you know, when I extend the elbow to do a distal interlock, you know, you can look at the flexion arc of the elbow, but also, you know, the AP view of the distal humerus can give you a clue that it's pretty close.
I just had a struggle with this today in a humerus non-union. You know, the other thing that I find helpful is to use the internal and external rotation of the contralateral shoulder. But of course, you know, in a non-union, the shoulder is stiff, and so, you know, confidence can be low. But I agree, radiographic profile, proximal and distal. Yeah. And then I think rotation can be helpful as well. You can even break scrub and check the other side if you need to.
Yeah, so afterwards, she was unrestricted motion, weight bearing was tolerated. She was back to work at 4 weeks. Early 4-week x-rays looked pretty good. And then, and then she was fully healed at 3 months. Pretty much back to doing all activities, but she definitely still has shoulder pain, which I found that in a lot of the ones that I've done, they have just vague nagging shoulder pain a lot of times with overhead activities, and so that's a real thing I think to talk to people about, because I'm not sure if they would have had that if I chose to plate her. Maybe she would have done better. Do you guys find that in your practice?
Well, yeah, I mean, not to nitpick, but you see where this starting point is. Like, this is right in that sulcus where the Sharpie's fibers of the supraspinatus are. And so generally try to get, this generation of nail is now straight. So you can get this way on top of the head and really go through cuff muscle and not the tendinous part of it. So that may contribute. I don't know. I mean, certainly you go through the shoulder and people can have some pain.
Your AP image is a nice example of how you might evaluate rotation intraoperatively. You have a proximal humerus that looks like a good conventional profile. Then you can imagine if you were able to zoom out a little bit, you'd have a pretty good looking AP of the distal humerus as well.
Nice, good case, Joe. You hit the next.
All right, so this was a 85-year-old, so a little bit older now, who tripped on a rug while she was dancing. She had a radial nerve palsy on presentation, a relatively dense one too. She had pretty much no motor and no sensation. But at baseline, she's pretty active. She lives independently. She does most things for herself. She depends on her arm for sure. And these are the terrible images that we have. What are you guys' thoughts?
It's, simple long oblique pattern, distal metaphysis not quite entering the metaphysis. Be reasonable to talk to this patient about a trial of non-operative treatment, as has been pretty well established in the literature. Just because the radial nerve is out doesn't mean that you need to do anything, although it can be a little bit more compelling for me, I would say, when the radial nerve is out. But this would just be, for me, the same discussion that we've been having all along in terms of the pros and cons of early aggressive surgery versus a trial of fracture bracing. I guess when the radial nerve is out, I do lean a little heavier towards surgery, even though the rates of recovery are the same if you believe the literature. It's just added patient difficulty to be in a cock-up wrist splint and a fracture brace and not able to extend their thumb and their wrist. And so that is relevant for me.
Yeah, this is one I think would be very hard to treat non-op, really. Just the age of the patient, the presumed frailty. It's the surgery she needs is a not insignificant in caliber, but I think that's better tolerated than a few months of bracing or pain.
Do you find that your conversation changes in the elderly? Like, do you push them more towards operative fixation?
Yeah, probably. I mean, it depends on the elderly patient, but yeah, I think they tolerate non-op a little less well than somebody who has more upper body strength, more agility and better eyesight, all the things that go along. So I just think it's harder to do non-op in an elderly.
It's a pretty interesting decision, right? Because it's definitely harder to manage them non-op, but also, the risks of surgery are more. And so I'm never really sure how to balance that, because I think both those things are true.
Yeah.
Yeah.
It's more of a question than an answer. But.
Yeah, that's a good point.
Yeah. And what do you guys think about how to fix this? Is this a open plating all 100% of the time?
Yeah, posterior approach, clean clamp lag, posterior plate is what I would do.
Yeah, agree. Simple pattern, widely displaced, nerve is out. You want to examine the nerve. And so to me, I'm going to do open from the back. I saw there was a question in the chat about tricep split versus paratricipital. My preference is lateral paratricipital. I think it gives you the most distance up the humerus, and then, just feels a little more soft tissue friendly to be going around the muscle rather than through it.
Yeah, for whatever reason, the tricep split approach is always like the first answer anybody ever gives, like especially residents, when the first thing they read, it's tricep split, because that's still taught as like a great option. I don't see a reason why you would ever really need to split it when you could go around it.
Yeah, I agree.
So that's pretty much exactly what we did for this one, and this has happened a couple times to me, and especially in elders that have these spiral humeral shaft fractures. They have non-displaced proximal extension, and for this one, it was a relatively distal primary fracture line. So doing a posterior approach, I was still able to see that extension and fix it appropriately. I've had it where it's proximal as well, and if you're doing a posterior approach, it makes it much more difficult to actually get to that more proximal fracture line. Like your plate essentially ends at the top of that. And so just really critically analyze your x-rays, especially if it's one of the more proximal patterns. And so for me, I again, posterior approach, triceps reflecting all the way up, clamp multiple small lag screws. I think the 2.4 lag screws work pretty well in osteoporotic bone. You can put multiple of them, so you get multiple points of fixation, and there's pretty low risk that you're going to propagate fracture lines and connect your lag screws. And it's strong enough for you to then essentially put a good neutralization plate on and not have to worry too much that your plate is then going to malreduce and cause your lag screws to fail.
Just actually, speaking of splitting, for me, once you get all the way up proximal with your plate like this, sometimes I do like to make a split in the triceps, because way up there, you're just in the meat of it. And so I think you can avoid some dissection by doing a small tricep split once you're way up above, just to place those most proximal screws. This probably is a little different since you had lag screws there. That implies that you already were up and working in that zone. But if you weren't, if you just needed to get the most proximal screw in your plate, that's one time to make a little mini split. If anybody has the Harborview tips and tricks book, I think there's a picture of that on the cover, if I'm not mistaken, or at least prominently displayed somewhere.
Because it's actually in between the long and the lateral heads prior to them getting into that common tendon, and proximal to the medial head. Yes, I agree. That works pretty well.
So she did well. Again, weight bearing is tolerated. Her nerve function actually returned at 6 weeks, so relatively quickly.
I do think the nerve recovers quicker with reduction and fixation of the fracture. I mean, it just makes sense, and anecdotally, that seems to be what you see. You know, if a nerve is injured, it doesn't want to be constantly draped over the sharp edge of the humeral metaphysis.
Totally.
Yeah, I think that's what a lot of people feel, and it was never really borne out in the literature at all. And I found this one article just a couple of years ago, is just a review looking at pretty much a lot of the data out there, and they did find an earlier return of the radial nerve with early operative fixation. And so hopefully more stuff comes out about that, because it just makes so much sense that the nerve would recover if it's not constantly being irritated by a moving fracture. And also, interestingly enough, if they operated late, the nerve was less reliably came back. So I think there's something to it. Hopefully more things come from it.
If the nerve wasn't out here, there's a question in the chat. If the nerve was not out here, would you consider doing this through a different approach?
I would consider it. I think still my preference would be an open plating. I think I get the most stability from that, and with a pretty low complication rate. So I think my preference would still be for plating, even though I don't see anything wrong with trying to do an intramedullary nail. I know some people who maybe even do a retrograde nail. I don't think there's anything wrong with that. It's just not my personal preference.
How about some type of extensile anterolateral approach for that location of the bone?
Yeah, I think it's tough to get fixation distally. I think we didn't plate onto the condyle. We didn't use one of the J plates. Like, we were able to get enough fixation distally, especially with our lag screw. But it gives you that option if you needed to plate onto the condyle. So for me, that's anything in that distal part of the humerus is a posterior approach.
Awesome, great case. Maybe we'll just go a few other. We just answered some. We actually answered a number of these, but just a few rapid fire. Joe, describe how you position like that last patient for the posterior plating.
Yeah, I started out in practice doing them all in the lateral position, and I think that works really well in more distal patterns. If I'm doing a posterior approach and I think I need to expose more proximal, I'll put them prone now. It gets their whole body out of the way, and it just makes imaging a little bit easier. So if I have to image the more proximal shaft, I'll put them prone. For distal injuries, I'll still go lateral.
Nice. How do you determine how many distal interlocks you need for an intramedullary humeral nail?
That's a good question. I was going to ask you guys that. In that case that we showed, I only had 2, and it wasn't that distal to the fracture site. I think if you have two screws that have purchase, they're not just floating in osteoporotic bone. I think that's reasonable. Otherwise, the more fixation, I think, the better in osteoporotic bone.
Yeah, I generally use, if it's proximal or simple, I use 1 screw. If there's a length of comminution like you had, I would use 2. If you're really pushing the limits of how much nail is contained by the distal canal, yeah, then it gets into maybe you want 3, but that's pretty uncommon. Usually 1's sufficient, but that's a pretty extreme kind of zone of comminution and short segment that you're nailing into. So anyway, that's tagging stitch in the cuff footprint to manipulate the head. It's just kind of a tip somebody mentioned. That's a good idea. Any role for tens nails 2022 for any of these fractures we've seen? No, probably not. I would say probably not. Pretty, it's still a surge. It's still an anesthesia and some incisions, and then really probably suboptimal fixation, I think, would be pretty non-controversial there. Let's see what else. All right, good. I think that's most of malrotation we talked about. All right, great. Well, that's good. So why don't we 6:05 or 9:05, depending where you are, why don't we move on to Journal Club? So this is a paper. These are always interesting, and at least, if nothing else, important to know about. Large randomized orthopedic trials published in non-orthopedic journals, so they don't always come across our email feeds, but often in the lay press and the source of controversy and methodology that we're not used to seeing in certainly surgical trials, orthopedic surgery trials. So I'll present some of the details on this, and then we'll get some of our panel's take and interpretation. So this was a trial done at 2 centers in Finland, 82 patients. They had closed unilateral displaced diaphyseal humerus fractures, and then they were randomized to non-op treatment, almost exactly using the same protocol that we for bracing that we talked about here, or ORIF with plate and screws. They identified their primary outcome was a DASH score, which at 12 months, in which the lower is better, and they powered the trial to detect a 10-point difference in the DASH, which was the kind of determined minimum clinically important difference. So they powered it to 58 patients per group. They ended up getting 44 and 38 or something. This is in the paper, their diagram of the fracture zone. So above, and this is any fracture line extension. So they need to go from all within surgical neck, 5 centimeters in the kind of above the supracondylar region. And then specifically these proximal fractures where the deltoid is proximal oblique, where the deltoid abducts the proximal fragment. These patterns were excluded. So here are their results of their primary outcomes. So again, out here at 52 weeks, the dash score again, lower is better. So the numbers go down as time goes on. So no difference at 12 weeks. So, 12 months. So they concluded no benefit in surgery over non-operative treatment in kind of all comers, all fracture patterns of diaphyseal humerus fractures. But it's interesting, if you back up here, a number of these are actually statistically significant. Bracing having poorer dash scores kind of throughout and more exaggerated differences at the earlier time points, particularly at 12 weeks. So as most large trials do, these investigators identified a whole host of secondary outcomes, and they decided based on a number of factors, why, the reason they chose the primary is that it was the most clinically relevant. And so that's predetermined. But then some interesting points kind of deeper in the data. So these were some secondary outcome measures. Surgery is the blue circles, bracing is the red square. So in the upper left, constant Murley. So this is a shoulder outcome score. So statistically and clinically significant differences for the first 6 months as far as shoulder function in the operatively treated group. Again, plated humeral shaft fractures. Lower left, so this is the proportion of acceptable symptomatic state. So it's kind of one of these newer types of outcomes where they ask patients, like, do you feel like this is acceptable to you? Patient-specific scores. And interestingly, and a bunch of these were statistically significant too. So patients felt their symptoms were appropriate significantly more often in all these time points in surgery compared to bracing. They asked a few more kind of similar but different specific questions. Satisfaction with your upper limb function, surgery better, at least in the first 6 months. And again, things, as almost always they do, converge at 1 year. And then lower right, adequate clinical recovery. So these were patients who, the question was, do you feel like you've recovered adequate clinically? So pretty kind of universally differences across the first 6 months as far as shoulder function, patient acceptability, symptoms, etc. So pretty interesting. Some other interesting findings: non-union rates. Pretty good to see that these are pretty in line with what we've seen from other cohort studies, non-randomized trials. Non-union rates for surgical treatment, 4%. Non-operative treatment, 22%. So again, most have shown kind of 80 to 85% healing rates. Interestingly, of the 44 patients randomized to non-op, 13 of them crossed over. So over a quarter crossed over because they couldn't tolerate the non-operative treatment and requested surgery. Iatrogenic radial nerve palsy, also kind of right in the same range that we see in many other studies, about 8%. So again, really a ton of complications potential in any surgery, but this is one I think specifically important to talk to any patient who's going to undergo ORIF, particularly from a posterior approach, but actually anterior approach as well. And then they asked patients, would you prefer the same treatment you got? And 97% who had surgery said yes, and 71% who had non-operative treatment said yes. So yeah, so that's the last slide. So Joe, maybe I'll start with you. What's your take on this trial? Had you seen this trial prior?
I had, but I had not looked into it and the depth that I did in the past couple days. I mean, I feel like it's a little misleading. Like, you could just as easily have titled it plating humerus fractures gets you an earlier return to higher function and more predictable outcomes than non-operative treatment, right? So I mean, I think it's a little misleading. I think the crossover rate was, like, they mention it, and I think the authors know that that's an important thing because they mention it even in their abstract and conclusion. But I mean, I feel like it's so important that it almost shouldn't be titled what it is. And the people that did cross over once they did get fixed, they had worse outcomes at 1 year than if they had gotten fixed earlier.
Yeah.
So
Cool.
I mean, I don't know. It's
Yeah.
the methodology is great, but
So Julius, let me ask you a little more of a philosophical question. Why do we see these in all of these fracture, op versus non-op, implant 1 versus implant 2, clavicle, distal tibia? Why do we continue to so emphasize the outcomes the ultimate outcome at 1 year? And kind of like the flip side is, why don't we, and how much does it matter in your mind and in what you perceive in patients' minds, less pain, better function in the first 6 months, even if they're going to be no different at a year?
Yeah, that's a great question, and it's such an interesting question. I think some of it is just historical and probably antiquated, right? We have these studies that perhaps comes from other branches of orthopedics, joints, spine. When you're really interested in 1 year outcomes is sort of where you're really laser focused on. And we have these tools, we have normative data. And so I suspect that's a lot of it. But I think you're hitting the nail on the head, is like, for trauma patients in particular, the first 2 weeks, first 6 weeks, the first 12 weeks, all those things count, and all those things sort of get swept under the rug. So, like, you mentioned the clavicle, like, you really have to dig through the clavicle RCTs to find how much better people did in the first 2, 4, 6 weeks. But that is meaningful to patients. So yeah, so I think that's partly a historical thing, but I think we're doing ourselves a disservice by not paying attention to the early benefits of skeletal stabilization
Yeah.
in this location in particular.
it looks
Perfect.
like the original design of the study, they even say that they tried to look at outcomes at various time points before a year as the primary outcome. And even like midway through the recruitment process, they changed to only look at it at 1 year. So I'm not sure why they did that, but
Yeah, cool. So here's a question. How about back to Julius? When you're talking to a patient about humeral shaft fractures, fixed versus not, how does tobacco come into your thinking or discussion?
Tobacco doesn't come into my discussions so much because first, just to be fair, we don't have that many smokers, but I've found it to be non-modifiable. So unless you're talking about some elective, malunion repair or something like that, if the patient has an acute fracture, I'm going to treat it with the treatment I think is best, regardless. I'm going to encourage them to stop smoking, but if they say they can't, or if they're cheating, I'm not going to check them in the preoperative area. I'm going to treat the fracture with whatever I think is best, smoking or not. Nice. Especially in this location where the soft tissues are forgiving. It's not like a pilon or something like that.
So Joe, how about in the non-union situation where it's a little more elective, but still pretty debilitating? Do you mandate patients prove they quit smoking prior to treating them?
I don't mandate it, but we have a pretty long conversation about it. And I tell them, if you don't smoke, if you don't stop, and your non-union doesn't heal, then I'm definitely not giving you a second chance until you correct some of these modifiable factors. So
Nice. And then just answer to a question. Yeah, the reason for the crossover, it's pretty interesting, right? I mean, it's something you'd want to know why. And interestingly, they really don't specify. They do clarify that these were not patients that went on to non-union and then needed surgery. It wasn't that situation, but they didn't specify the time course, whether it's like 2 weeks not tolerating brace, 6 weeks still gross motion, 3 months questionable delay from certain whatever. So not clear. But it was patients who decided at some point prior to anticipated union elected for surgery. Yeah, good question. Let's see, how valuable are patient-reported outcomes moving forward, and how does it affect your decision-making? Anybody got a good answer for that one?
I think ultimately we're doing what we're doing for the patient outcomes, and so they're very important for me at least. So it's impactful for me to see that the outcome is the is the same arguably at 1 year, and so I use that information. I think, as mentioned already, the thing that you can't sweep under the rug is what happens in the first few months.
Yeah, nice. Julius, back to your MIPO case, quick question. Intraoperatively, how do you decide if your reduction is going to be satisfactory? Are you just kind of like fluoro gross alignment? Are there any keys?
Yeah, I'm doing fluoroscopic gross alignment. It depends. I've done MIPO in the simple pattern, and that gives much more heartburn, I will say. And so I spend a lot more time fretting about not having like a transverse or short oblique with a large gap. But something like the case I showed, I'm just going for, gross length alignment and rotation, which, mostly can be done fluoroscopically. And then, comparing shoulder motion to the contralateral side is an adjunct that I use.
Yeah, and it's interesting. I saw Dhira Chai from Thailand had a question earlier. I don't know if he's still on, but he's got a vast experience in MIPO surgery everywhere, including the humerus. And and I see case series from people who use this technique a lot. And interestingly, counterintuitively, even simple fracture patterns that are not well reduced with the MIPO technique seem to heal very readily. I don't know if it's the long bridge span or the favorable biology, but I hear you. It's not one you want to just leave gapped and bridged you would in your mind, but it actually seems to maybe work out okay. And any thoughts about treating nerve contusions or transection? What do you do in the case where, I guess nerve contusion, we probably would all agree, not much to do, or if anybody has something else, but kind of watch and wait. How about a transection? Do you tag them and tag the ends or close or repair yourself?
if I think they are, it's hard to know if they're transected like prior to the OR. If I have some suspicion, like if it was a penetrating injury, or even for gunshots, I tend to get my peripheral nerve surgeons involved early. I've had a few cases where they do simultaneous approach with me and take a sural autograft if it's actually transected and they need to do that in the acute setting. So I just get the peripheral nerve surgeons involved early. But if it's a case where I find that it's transected intra-op, I'll usually tag it and then talk to them.
Yeah, great. All right, fantastic. Well, we're coming up on time. Why don't we wrap things up unless you guys have any final comments or thoughts? So quick commercial for future ones of these. These have been huge audience favorites. So we'd encourage you to join some of these ones in the future. May 31st, topic is proximal femur fractures, intertroch, subtrochs, and then the atypical femur fracture varieties. And then June 7th, there's a session on geriatric distal femur fractures. So sure to be chock full of good information. Finally, there's a really popular and highly used AO YouTube channel. And so you'll get a link to this recording within 24 hours to access later at your convenience. So why don't we adjourn there? So so thanks so much to Joe and Julius, and thank you all for joining us. We hope you enjoyed your evening or morning, wherever you are, and look forward to seeing you again soon.